morning, everyone. Thank you so much for joining us in this virtual webinar. My name is Gary Painter, and I direct the Homelessness Policy Research Institute here in Los Angeles. I know that most of you have participated in an HPRI event before, but for those of you who might be new or coming to this topic, we wanted to express a warm welcome to you and welcome to those who have attended events in the past. Just say a little bit about our mission. The Homelessness Policy Research Institute exists to help accelerate solutions to ending homelessness that are culturally informed. And we do that by creating transformational partnerships between policy, practice, and research. And, I think this is a great example of some of the partnerships that are critical to address some of the issues among our homeless population. And today I'm really excited to welcome you to this webinar on older adults experiencing homelessness. As you'll see, we have a terrific researcher who's going to begin our presentation today. And then we have a wonderful panel which represents people who work in homeless services, who lead organizations that are providing housing for older adults. We have folks who are actually building housing for older adults, and we have a tremendous advocate who has experienced homelessness herself. We intend to have that conversation to really give critical insights into how we all can do more to end homelessness. And today we're speaking about older adults. To begin our webinar today, and I should say before we begin our webinar today, you are probably also very familiar with Zoom webinars by now. We have a question and answer feature that I would welcome you to address questions in. After the research presentation by Dr. Margot Kushel, what we're going to have is about 10 minutes to address your questions and answers based on our presentation. After that, we're going to move to a panel, which is going to be moderated by Galiana, who is the Older Adults Coordinator at LAHSA here in Los Angeles. And then there will again be a question and answer session after that panel. So please feel free to pop your questions in as we go, and I will monitor those in the first session, and then Jean will monitor them in the second. So without further ado, I'd like to welcome Margot Kushel to the front of the virtual platform. She's going to begin sharing her slides. On the event page, you'll see her full bio, and you'll note, as noted even on the slide, that she comes from UCSF. She's a professor of medicine. She's the director of the UCSF Benioff Homelessness and Housing Initiative, and she is a world-renowned researcher on older adults experiencing homelessness. Without further ado, I'm really pleased to turn over the virtual platform to Margot Kushel. Thanks, Margot.
Thanks so much for having me, and thank you for being here. I'm just going to talk today a little bit about our research on older adults and homelessness, and just focus on a few key new findings. Just to level set here, as many of you are likely aware, the population of single adults experiencing homelessness is aging. In research that we did now many years ago, we found that in 1990, approximately 11% of single adults in San Francisco experiencing homelessness were 50 and older. By 2003, when we stopped the research, 37% were. And now looking at local point-in-time data, approximately half of single adults in the Bay Area and in many parts of the country are 50 and older. We've learned from our colleagues, Dennis Culhane and others, that this is really a generational effect, that Americans born in the second half of the baby boom, approximately 1955 to 1965, have had an elevated risk of homelessness throughout their lifetime. You can see here in the green line, that was in 1990, there was a big bubble of people who were single adults experiencing homelessness in their 30s. By 2000, that big bubble of people were in their 40s. And by 2010, that big bubble was in their late 40s or early 50s. And happy to talk in the Q&A of why this may be, except to say that the same colleagues explained that this trend is going to continue. And in fact, we plan to see the biggest group of increase in age of people experiencing homelessness, so they're 65 and older, whose numbers are expected to triple between 2017 and 2030. I'm going to talk today about findings from a study that I've been doing since 2013 called the Hope Home Study, which stands for the health outcomes of people experiencing homelessness in older middle age. The study has been funded by the National Institute on Aging. It's a longitudinal cohort study. We enrolled 350 participants between July 2013 and June 2014, and an additional 100 people in 2017 to 2018. To be in our study, on your first interview, you had to be at least 50, you had to speak English, and you have to be homeless by the federal definition or the first acted enrollment. And we've been following people since then every 6 months at interviews. When we first met people, a few key findings. Like in many studies of single homeless adults, the preponderance were men, so 77% were men. 80% were African American. This study was done in Oakland, California, where at the time we did it, approximately 26% of those in this age group were Black. We cannot have any conversation about homelessness in America without talking about the ongoing effects of structural racism as one of the main drivers of homelessness. We found a 3 to 4-fold elevated risk of homelessness for Black Americans, and that has been held out in every study of homelessness. People in the study were very poor. 90% had an income of less than $1,150 a month. And importantly, the median age of our participants at baseline was 57, with an age range of 50 to 70. But median age meaning that half of the people were 50 to 57 and half were 57 to 80. If you remember nothing else from the study, perhaps remember this, is that of everyone in the study, everyone had to be 50 and older and homeless if they were in the study. A full 44% had never once in their lives experienced homelessness before the age of 50. You can see that another 19% for the very first time in their life experienced homelessness in their 40s. So nearly half of people who were over 50 were first homeless after the age of 50. Our study participants reported poor health in every measure. This is a very simple question that we like to ask people that actually has very strong prognostic value of whether people are going to wind up in a hospital or wind up dying. And that is, how do you rate your health? Poor, fair, good, very good, or excellent. And over half, or 56%, reported their health as fair or poor. Really, the only general population where we see this in is the very old, people in their 80s and 90s, with such a high group of people say their health is fair or poor. We found very high prevalence of many chronic diseases, even though we assumed that these were understated because people had very poor access to healthcare. If you don't have access to healthcare, you might not know, for instance, that you have diabetes. But in our participants, 14% have been diagnosed with diabetes, 5% with HIV, 6% with a major cancer diagnosis before they enrolled in our study. We found a very high proportion of people with functional impairments with difficulty with the activities of daily living, where nearly 40% noted at least one limitation in activity of daily living, and nearly 50% with a limitation in instrumental daily activities of daily living. These impairments are things that often lead people to require nursing home care and are signs of advanced aging, despite the median age of 57. When we did cognitive testing, we found very high prevalence of cognitive impairment. Almost a quarter had evidence of global cognitive impairment, and 35% had evidence of impairment in executive function, which is the ability to follow sequence tasks like, oh, if you want to find housing, you need to go to this office, on Monday, Wednesday, and Friday before noon, and then you have to go to that office. That's something that's very difficult for someone with cognitive impairments. Alcohol and drug use problems were common. About 2/3 had moderate or greater severity of drug use symptoms, with cocaine being the most common drug, and about a quarter had moderate or greater severity of alcohol use symptoms. We found in our sample that incarceration was an extremely common experience. At enrollment, 84% of our participants reported at some point in their life they had spent at least a night in jail, and over a third, or 37%, had been in state or federal prison. This really speaks to the enormous risk that having a history of imprisonment places in someone's risk of later becoming homeless. At the enrollment interview, despite the median age of 57 and the lower age being 50, a full 14% were on probation from jail and 7% were on parole. This is from work that I've done with my colleague Alana Garcia-Grossman, which is currently under review. We followed people over years, and we found, despite their frailty, maybe because of their frailty, this enormous risk factor for being incarcerated during the study follow-up period. In a median of 52 months, so over 4 years of follow-up, we found that a quarter spent at least one night in jail in our study follow-up period. And you can see that about half of those had one jail stay, but a not insignificant proportion had 2 or more jail stays under review in that follow-up period. When we looked at what was likely to be a risk factor for winding up incarcerated, we found that the older you were, you had a slightly lower risk of winding up in jail. Being a man had a dramatically higher risk of being in jail than being a woman. Having more social support or 6 or more confidants was a very high risk factor for winding up in jail. And being homeless at follow-up. So if you are homeless, if you continue to be homeless, you are much more likely to be in jail. Hard to sort out whether this is because being in jail kept you homeless or being homeless more likely probably put you at higher risk of winding up in jail. Other risk factors, being drinking, problematic amphetamine use, and you can see that the single biggest risk factor for winding up in jail was being on probation or parole. As you're probably aware, California has some of the worst rates of keeping people on parole and sending people to jail for parole violations. In those 15 over, we found a very high prevalence of all geriatric conditions. Sorry, the slide is in the wrong place. Just to remind you that, despite a median age of 57, people were really very frail. We have seen an extraordinarily high mortality rate amongst our participants. Of the 450 people we found, 83 we know to date have died. For those who we know the dates of their death, the exact dates of their death, the median age of death is 64, with a range from 54 to 77. Of the original 350 participants at the median age of 57, 74, or more than 1 in 5, have already died. Of the people we've recruited in the last 2 years, 9 or 9% have already died. When we look at what predicts people dying, and we did an analysis that basically looked over time at how you responded to the interviews and what made you more likely to die in the next 6 months, we found a few interesting things. In this model, and this is work I've done with my colleague Rebecca Brown, who's now at Penn, we did not include any use of the healthcare system as a potential, in this model. We found that those who were older were more likely to die, and those who first became homeless after 50, as opposed to those who first became homeless earlier, were at almost double the hazard or risk of dying. We found that if you were homeless, as opposed to housed at follow-up, you had almost double the risk of dying. And if you were in an institutional setting, either a nursing home, a jail, or other institutional setting, you were at significantly higher risk of dying. Interestingly, we found one of the best predictors of dying was just asking people how they rated their health. And people who said that they had fair or poor health were at almost double the risk of dying. And those with 2 or more chronic conditions. We often pull ourselves in pieces of how we're going to guess risk of whether people are going to do poorly. And this would say, just ask them how they would rate their health. It's actually an incredibly potent risk factor. In this model, we included whether people visited either emergency departments, inpatient care, or nursing facilities, thinking that this is another way to think about it. If we were to try to pick the people who were most likely to die, what would be the things? And we include those as markers. Once again, first becoming homeless after 50 is a very potent risk factor. Self-reporting fair or poor health. Being seen in the emergency department at any point in the 6 months prior is probably a marker that you're at higher risk of dying. as well as being admitted to a skilled nursing facility. So as I sum up, I just want to say, as we all know, homelessness is reaching crisis proportions. The aging of the population increases our urgency of action. Almost half of older adults, and older adults make up about half of all single adults, almost half of those first became homeless at the age of 50 or greater. And despite a median age of 57, the health of our population is similar to those in their 70s and 80s. Incarceration is common despite frailty of the population. Older adults who are first homeless in late life are more likely to die. Self-reported fear for health is a strong predictor of future mortality. We desperately need action to prevent entrance into homelessness in late life, and we need age-specific interventions to end homelessness. With that, I'm happy to take questions. I invite you to follow me on Twitter, and this is my email address, and I'm happy to take any questions you have.
Thank you so much, Margot. I mean, these are just really devastating data. And I think from my own view, the interactions with the criminal justice system are not well explicated in the conversations that folks are having. I wonder if it's just a matter of having not brought these data to folks. And there was one comment in the Q&A that someone else's own research was finding similar things here in Los Angeles. Do you have a sense in talking to folks why people aren't appreciating that connection, especially around people who have, parole violations or probation and those kinds of things?
The connection between homelessness and incarceration?
Among older adults specifically.
Among older adults. I think it's a relatively hidden problem. Like, it's not in the public imagination, and you have to really ask yourself, like, what are we doing? Like, what interest are we serving? These folks are so vulnerable, they're so frail, and they're just getting picked up constantly and put into incarceration. And it really interrupts everything. It's humiliating, it's dangerous. We've seen with COVID how intensely dangerous it is.
Right.
And I just don't think it's part of the public conversation. And I think we kind of need to lift it up and make it there and actually really question, like, what are we doing?
Yeah, there was one specific question about a piece of data that, and I'm not sure if I understand it completely, mentioned 6 or more confidants.
Yeah.
And I wondered if you could share a little bit more about what that meant.
Absolutely. Like, we were, to be honest, anticipating that if you were socially isolated, you might be at more risk. And so we asked this question, which is sort of a validated questionnaire of like how much social support you have. And in the general community, if you have 6 or more confidants, you're viewed as having social support. In homelessness, we often talk about just even having 1 or more versus having none. And what we found, in fact, that the people who were getting placed into jail or getting arrested and put in jail were actually more likely to be in social networks than people who were not. And we think that, we don't know for sure, but I assume that this could be that people are, that the people who are sort of quietly staying by themselves, as we know many of our homeless elders are sort of not being picked up, not being noticed. But the people who are involved in a lot of interactions, in fact, are more likely to be picked up. And whether these interactions are, involving, like, we know that violence and victimization go together, but we don't think that most of the arrests were to anything violent. It may just be people are sort of being picked up more. We know with sort of sweeps of homeless encampments and things that people get arrested for doing things that are really survival behavior. People get arrested for urinating in public. People get arrested for drinking in public, where any of us who are housed can have wine all we want at home. And so we think there's something about sort of being involved in sort of social networks that are gaining perhaps the attention and getting people picked up by police in this really devastating pattern.
Yeah, thank you for sharing that. There was There's a couple of other questions around kind of how you interpret the data on institutionalization and knowing that these might be associated with mortality, but maybe there's not a causal chain that you can identify yet in the data. Could you say something more about whether you think certain kinds of institutionalization may be better or worse for older adults to prevent mortality?
Yeah, I mean, I think the nursing home data may in fact be a marker rather than a cause. I don't think necessarily that, although with COVID, of course, nursing homes in some have been a cause of death and that COVID spread so quickly.
Yeah.
But in general, what we see is it's actually relatively hard for folks to get into nursing homes, because what we see a lot is that people go into the hospital, they have, very severe illnesses, they might be sent to a nursing home. But before that 3-month Medicare benefit is up, people are getting sent out to the street. And we've seen some really horrifying things of, my team calling me and saying, I just found Mr. So-and-so, he's got tubes coming out of his kidneys and a new amputation, and he's on the street, which is really horrifying. The people who actually remained in nursing homes were often people who were there in hospice care. And so that may be more of a marker of illness than a cause of illness. But I think it's important in that, we use all these different vulnerability indexes and sort of trying to figure out who's likely to do poorly. If someone was in a nursing home and is no longer in a nursing home, that should raise our thing that this is someone who needs extra support. This is someone who's at a lot of risk.
Yeah, thank you for that response. There's a couple of questions around particular kinds of interventions and effectiveness at either reducing elder homelessness or, preventing negative mortality outcomes. Have you, in your research or others, would you be able to uplift particular kinds of interventions like whole person care or others that are effective?
Yeah, I mean, I think what we saw for elders first becoming homeless was that usually it was people who were low-wage workers throughout their whole lives. So a lot of people in physically demanding jobs who became homeless after one or two of the following events. Either they got sick and could no longer work, they lost their job because of job displacement and really had trouble competing in the workforce. Their spouse or partner got sick, or their spouse or partner lost their job. Their spouse or partner died, or their mom died. We saw a lot of people who were living with mom, working, let's say, in a warehouse. Mom died, they didn't have tenancy rights to that apartment, and they became homeless. I think we need to be much more aware of these risk factors that are displacing our elders into homelessness, and we need to act quickly. Because what we heard when we did qualitative interviews with this population is that it was incredibly disorienting. It was often during a very difficult time in their lives. They became sick, mom became sick, mom died, they lost their job, and they felt like there was nowhere to go for help. And that was really striking. They just felt like they tried and no one was available to help them. I think we need to recognize that our seniors, who are often spending 50, 60, 70% of their income on rent, have no ability to sustain any kind of shock, any kind of rent shock, loss of job. It was just as common for people to report that it was someone else in the household who no longer paid rent as they were having trouble paying rent. So someone else in the household lost their job, someone else in the household died. I think we need to do a lot better job of identifying people who are at risk and intervening to keep them where they are than we're currently doing. Because these are folks, if you've never been homeless before the age of 50, these are not people who have major behavioral health problems. These are people who basically had, as we see in many minoritized populations because of their weathering effect of racism, sort of premature aging. And they just are really, need a little bit of an uplift. So you see things like the state has this program now, Home Safe, where using the APS system, the Adult Protective Service System, basically can provide homelessness prevention to people called into that system. That's probably going to be a relatively good mechanism, but I think we need more focus on homelessness prevention among olders and looking at people living in high area deprivation index neighborhoods where the ability for their their loved ones to have extra money on hand to help them is less. I think we need to look for people who are paying high, severely rent burden. And we need in every system, whether it's the medical system, the social service system, the unemployment system, any system, to recognize these shocks as potential triggers and bring help to people where they are before we let them lose that housing.
Absolutely, absolutely. There's two last questions I want to kind of give you in rapid fire, as we and you can answer them in whatever order you think is best. Someone noted that 80% of your sample are Black men, and as you noted, a primary cause of homelessness
or Black, not all Black men.
Oh, okay.
Black. Yeah.
Are Black. Okay. That one of the causes of homelessness that we have known from much research is structural racism. There's a clear intersectionality between criminality, criminalization, incarceration, among the Black population and homelessness. And so one of the questions has to do with what you might imagine if either maybe you're doing additional research or you might suggest should be additional research there. And the other question is, again, more kind of what you might suggest. Do you think our administrative data systems are sufficient to capture some of the subtleties that you're uncovering in your research? And if not, how could they be brought up to the level that we can actually make informed decisions?
Yeah, I think that I worry that we've done things like use fair housing laws, which are obviously good things, and weaponized against them Black communities. So when we talk about prioritizing, the Black community, so it's such incredibly increased risk for homelessness, we're like, oh no, we can't do that because that would be unfair. That would violate fair housing laws. I think we need to have a more open and honest discussion of that. I'm going to lift up a paper I did with my wonderful colleague Derek Paul, who wrote about the effect of structural racism from our interviews, with our participants, and we learned so much, and we learned about all of these, this lifetime sort of history of both interpersonal and structural racism, and all the many ways it intersected and sort of wound up with homelessness. Starting with, the fact, the low transfer of intergenerational wealth because of basically the stealing that went in because of redlining and lack of access to mortgages and all of the other well-described things, because of the really just horrible history of criminalization of Black men and the ways that ripped apart families. What we heard was really interesting, the people who are first homeless before 50 often had histories of imprisonment, and they were really often difficult childhoods where and then were caught up in the juvenile justice system. And they talked about like the school to prison pipeline, and then were spit out of prisons in their 30s or 40s, and really were had faced so much extra discrimination because of criminal justice involvement. And then for the people who were first homeless after 50, very few had prison histories, but what they talked about a lot were these one-time charges, which were often like shoplifting when they were 18, or having marijuana, which is of course now legal and widely used by all populations, and how that charge that they had caught early in life haunted them throughout their lives when they applied for jobs, when they applied for housing, in just about every way. I think that we really need, as people concerned about homelessness, to really talk about all the insidious ways the racism in our criminal justice system has directly played into this, and all of the ways that the really theft of intergenerational wealth because of mortgage discrimination, because of lack of access to building wealth through housing, and because of ongoing sort of fair housing law violations really plays into this. And we need to step back from this individualistic notion, which you often hear in the popular press, of like substance use, mental health, when we know that people with substance disorders and mental health can be housed really easily, and actually have the much harder conversations about how all of the racism in sort of every aspect of our society has set up made this almost inevitable.
Well, thank you, Margot, for being very specific and giving critical insights as we move forward in doing what we need to do, which is to end homelessness among older adults. There are other questions in the box. If we have time at the end, we'll come back to them if you're able to stay with us. But now I'd like to turn it over to Jean Galiana to introduce herself and also the panel of folks who are on the front lines every day trying to house older adults successfully. And there's many stories of such successes. So again, thank you, Margot and Jean. I'm happy to turn it over to you.
Thank you, Gary, and thank you, Margot, for that wonderful presentation and your incredible research. It's one other thing I'd like to add is we're not only dealing with cultural and systemic racism, we are dealing with cultural and systemic ageism, which really has come together to create this storm that we're facing now. So I'd like to introduce our first panelist today, Zandre Johnson. And Zandre, would you like to tell us about what you're doing to serve homeless older adults and what challenges homeless older adults experience while trying to access service systems?
Hello, everyone, first of all. But in listening to Marga and all those, oh, that's just so troubling to me. It breaks my heart, you know, because I was a person that was in that system on that surfboard going through those numbers, being that statistic. One of the things that I'm doing to bring the flavor of difference is being an example, you know, because it is the systems that are failing us as older adults. I'm an ex-felon, formerly incarcerated, and I'm also formerly homeless. And I was homeless for like 2.5 decades, not really understanding my homelessness until 2010. I was 53 years old, my last bid in doing time. And in that 53-year-old, I was now getting housing. And that was a very, very hard navigation for me because of my background, my age. And if I was not a fighter and just gave in, I would still be out on the street, living in a tent somewhere and using portable toilets that are very, very unclean. But because I am a fighter, I was able to navigate that way and not give up, you know. The systems were designed in our neighborhoods for the Black and Brown communities to provide a help for us to be able to maintain some type of stability. I don't think when they designed the welfare system and the Social Security welfare system, they designed it to really, how can I say it? They designed it for temporary help, but not a long-range help. And a lot of people are using the systems long range because there's no alternative, but there was no plan for the long range. And meaning that if you're on Social Security, the plan of no long range is if you get a ticket to work, they could take away from you. If you get married, they could take away from you, meaning that you're senior and all of this is happening for you. And then in the welfare system, a lot of the parents who took care of the children of the parents that were in prison, they became seniors, they quit their jobs or they lost their jobs. They used the system to take care of the children of the people who were incarcerated. And then the people incarcerated got out and those parents died. You understand? And now those children are part of the system, have grown up in the system, and now they're that next generation of incarceration. So it's like this vicious cycle that is taking place. It hasn't changed. I never understood it until getting involved as a speak up advocate for Corporation of Supportive Housing, to be able to be in forums like this to understand the many numbers that are being placed in a community of colors, and no one is dealing with the system that created this homeless sector. This system has been being developed for a very, very long time. People started phasing into homelessness in 1864 with Ingleton in England. So there was homeless back in the century of days. But in Los Angeles, my mother moved into a middle-class neighborhood. My father lost his job. And he was going through some bout of alcoholism, and he was going through the military type of veteran, and he was doing post-traumatic stress disorder. And while he's going through all of this, we're continuously losing until there was nothing left. And so I from my own experience coming from that community, I saw a lot of my neighbors being in the same predicament my mom and dad was. So I figured it was something that was going on with the jobs or something. Maybe they were losing their jobs, but these homes were being lost as well, and the families were being displaced. Some people living with family members or whatever, you know, and it all became another part of the system. Parents went and got welfare, food stamps, And once you lock into those situations, it's like they almost do with you as they will. You know, they tell you that they want you to have a better life. They say that, you know, they suggest that, you know, you take what they give you and make life better. Well, let me tell you about my life doing this. I went through the shelter for 2 years. I couldn't get housing. I finally got enough guts in me to go down to Section 8 to do it. So I got housing. Okay, I had to talk for it, but I got it. Now that I got into housing, life is good. I get with speak up programs. I travel. I do all this different stuff. And then I'm growing older. I'm getting older, but I only have this amount of money to work with, which is they're taking all of my money for the rent almost and utilities, and God forbid I get a car. God forbid that, you know, or a monthly pass. God forbid that, because all of those are dollars taken away from my livelihood. So I get a job through Ticket to Work, through the SSI Welfare Department. I get a Ticket to Work. Now, I didn't never heard of it. Nobody's ever heard of it. So I get involved in the Ticket to Work if you do a work source. And they say, oh, this is what's going to happen. You work, this is what they're going to do. That's not what happened. I worked and they said, you know what? You were there a year and we forgot to do something. So we have to say that you owe us. So then they were taking this amount of money out of my check that I worked for. Okay. Then I got married because I fell in love. I got married. I was in love with this person for many, many years, you know. So we decided to get married, same-sex marriage. And then they send me a letter and say, well, we can only give you $144 because your spouse has a income from her deceased husband who was a vet. You know, so with $144 and my wife $1,200, we have a car, insurance, housing situations, two pets that we've gathered in this life. We have this life going on. And they said, well, if you don't maintain it with this, I don't know what to tell you. So I had to go back to work, you know, and now I'm at LA County USC hospital. I work with Cervicon, which is a contract with them, but I'm 63 years old and I have no choice. There are a lot of people like me out there right now that don't have a choice either. And they don't know to fight for all these things because they give up. They say, you know what, I'm tired. I don't want to do this no more. Because as soon as you get, they say you take 10 steps forward, they take you 2 steps back. You still have 8 steps, but a lot of people think it's all the way back. You know what I mean? So the system is failing us. Not the experts that do the stats and not the ones that, you know, do all the research. You're not failing us. It's the system that's in place that you give the research information to that is failing us, you know, because it's like a lot of people, my peers, because I was formerly, I'm never going to get away from formerly. They want what I have, just the small life that I have, that's good. But to fight to get to it is the hardest realm. And then during pandemic time, it's even harder because the connection is not there, you know? Everybody don't have Zoom and you can't go into the office. So it's now stagnated. Now we have that excuse, Zoom, pandemic is here. So we really can't help individuals. We have to send, you know, there's a lot of stuff going in there. But I know when I got out of prison, what I was faced with, I could have been on Skid Row, or I could have path and go to Skid Row, but fight for something that I believed in. I believed that I had a right to live and that prison shouldn't have been my death, being that I'm alive, you know? So I fought, but just how many sisters and brothers that don't get that fight, you know? So the system, it's not you all, you're doing the work. And I'm grateful for the work that you do. I really am, because I know you help many with information, doing the stats. I know that when you're in the offices and you're doing clients, you're doing your best job, but it's bigger than you all. It's a system that was designed for Black and brown communities called welfare. And it has never given anybody enough to survive, which caused criminal activities. And those criminal activities became a reason why you can't get the help. It's like a catch-21 forever. Until we change that system, this what we're doing right now is going to just be what we're doing right now. And it's going to only help a little bit of people who are able to fight for their life, even as seniors. And God forbid the parents that have not even had incarceration, but they took care of their children's children while they were incarcerated. And they used the welfare system to take care of those children that they were housing for medical and, food stamps or whatever. And then those kids grew up and that money went away. They lost their jobs. They gave up their jobs to take care of these children.
Yep.
So we have to look at everything. Homeless look different everywhere.
Well, thank you, Zandre. Thank you for sharing your passion and your incredible story. Speak up, and all of us are really, really lucky to have you as an advocate. And we thank you so much for sharing with us now. I wanted to move along to our next panelist, if that's okay. We're going to pivot to explore how the homeless service system can collaborate with providers of in-home social and healthcare services. It's important in this discussion because for decades, homeless service systems all around the country have struggled to house higher acuity older adults who can't live safely alone. We all know there aren't nearly enough boarding cares. We know the assisted living waiver has a wait list of 1.5 to 2 years. And getting a room in a nursing home is not only not always possible, it's not always the best option. So the homeless adults are often living with multiple chronic conditions and are often also unable to complete their activities of daily living. If we can attach homeless older adults to high-level in-home supportive services, it allows us to not only match that client to housing who otherwise would not have that option, it makes it possible for the older adult to stay housed and not fall back into homelessness. And lastly, this type of support can greatly reduce costly dependence on the healthcare system in the acute settings. So this is of great interest to all people, both human people who care about dignity, but also people who are looking at the bottom line of spending. So I'd like to introduce you first to Eve Gelb. Eve works with the SCAN Health Plan, and we'd like to hear her discuss their bold new initiative to serve current and formerly unhoused older adults. So Eve, would you just describe your organization, what you're planning to do to serve older adults and what you see as your biggest barriers or challenges?
Yes, thank you so much. And thank you for having us here. Thank you, Dr. Kushel, and to Zandra for what you've said. So SCAN's a health plan, a Medicare Advantage health plan. We serve about 220,000 older adults in California. But we also serve people who have both Medicare and Medi-Cal, and we serve about 35,000 of those folks. And what that allows us to do is engage in not just the healthcare delivery, but also the long-term services and supports that are really important. Dr. Kushel talked about folks who are experiencing deficits in their activities of daily living, cognitive impairment, and a lot of the services that are provided already today for younger people experiencing homelessness don't address those particular aspects of the need. So we are really working to say, how can we bring long-term services and supports to a population that is experiencing not only homelessness, but the functional decline and cognitive decline that comes with normal aging, but also is exacerbated with aging in a homeless environment. And I think the point that Zandra made about the family and Dr. Kushel is also important, because what this does is it enables us also to understand the caregivers. So focusing not just on those that are currently experiencing homelessness, but those that are vulnerable and at risk of losing housing for that same thing. Many of the people we serve are are caregivers for younger disabled folks or are caregivers for their spouse. And really, understanding that connectivity of all the humans involved in successful, healthy, independent aging is where we're going. So in addition to our current focus, which has been on preventing homelessness for older adults, we are now launching initiatives to support those who are currently experiencing homelessness. And this includes intensive care management with an older adult focus that can bring the long-term services and supports to bear. It also includes really relooking at how healthcare is delivered. Today, it's delivered in a very piecemeal fee-for-service basis, but with Medicare comes a capitation, a per individual per month payment that can be leveraged to provide a more whole person care approach. So that's what SCAN is embarking on, is trying to figure out how we can leverage that monthly capitation approach from both Medicare and, in our instance, also Medi-Cal to create a Medicare whole person model to support people experiencing homelessness, people at risk, their caregivers, et cetera.
Oh, thank you, Eve. This is really exciting to have a managed care organization that's been built on serving the highest acuity, lower income, older adults since 1977 to be stepping up to the plate here in Los Angeles. And we're super excited to see where that's going to go. But next, we also have another in-home supportive service and healthcare provider with us, Eve, Cheryl Wilson. Cheryl Wilson is the CEO of St. Paul Senior Services in San Diego, and she's here to tell us how they are able to successfully house the highest acuity older adults, meaning nursing home eligible, who were formerly homeless. And we're so excited to learn about this best practice case. So Cheryl?
Thank you. And thank you for the introduction. And thank you to the previous speakers who set the stage. I work with St. Paul Senior Services. We have St. Paul's PACE as one of our organizations, but we also provide assisted living, independent living, memory care, skilled nursing, a senior day intergenerational programs for people with Alzheimer's, and then children, babies ages 2 months to 6 years. And we just pretty much cover the gamut of providing senior care. And about 12 years ago, we saw the need in the community that there were more and more seniors on the street. Now, this was before we started doing the point in time counts, et cetera, but it came to my attention that this was a problem. So we met with city leaders, all the homeless people, et cetera, and got nowhere for about 6 years. And then got a call from our housing commission leader and asked if he would suggested that we partner with them on a project. And that was the beginning of what has become a great investment in the community for St. Paul's. So we now also partner with CSH rents space from us. So we're very involved with CSH, also with Wakeland Housing. And so we now do what's called a housing first model. We started to do this or think about this 12 years ago when nobody even knew what it was. And 6 years ago, we implemented it. So we will take people off the streets who are still addicted, still alcoholic, have major medical problems, as in 11 or 12 multiple chronic diagnoses, should be in a skilled nursing facility. But we place them into housing, put them into the PACE program. PACE stands for Program of All-Inclusive Care for the Elderly, and it truly is all-inclusive. Not only do we have doctors and nurses and nurse practitioners and therapists and dietitians and social workers, psychologists, psychiatrists, you name it, we have those people on staff and available to serve. So one of our biggest challenges, and we had to really amp up our PACE program to meet this challenge, was mental health. You know that if somebody's been on the streets for a year, 5 years, their mental health issues are overwhelming for them, which is why we believe that the housing first model is the best way to go, because it's very hard for people to get clean and sober when they're living on the streets, for goodness sakes. And if they're elderly and they have arthritis and their diabetes are out of control, et cetera, et cetera. So we believe the housing first model is the best in order to deal with these folks. So in order to really be good at mental health issues, we brought in a consultant. They did an evaluation. There were 2 universities involved. They gave us recommendations. We implemented all those recommendations. And at this point in time, we think we're pretty good at dealing with the mental health issues. We also have to teach life skills. That's a challenge. People, as Zandra explained, you know, they don't have life skills. They've been either incarcerated or they've been on the streets. They don't have a bank account. Just one of the interesting things was taking people to a grocery store and showing them how to shop, teaching some of the men how to cook, very basic items, showing people how to use a laundromat or how to use the laundry, life skills. We don't dwell on people's addictions, but what we find within 3 to 6 months, most of their addictions are resolved or resolving. And that is because they feel safe, especially women. Women feel very insecure, and our ladies like to have at least 2 locks, you know, two entry points so somebody can't get to them. And I won't go into all the details of how hard it is to be on the streets, but I think Zandra's kind of led us down that path a little bit. It is not an easy life for women on the streets. They are abused and taken advantage of a lot. So once they feel safe and secure, then they can start to work on their health care, and then on their mental health issues, and then on their addictions. We have less than 0.02% recidivism rate. Everybody says, who's not in this business, says, oh, these people, they just like to live on the streets. No, that's what they want. They don't. And once you provide for them, not only the roof over their head, but the care and the support that goes along with it, then these people are grateful, not to us, but for their own ability to change their life, to turn it around, and to become contributing members to the community. Many of our people can't get jobs anymore because of health reasons, but they volunteer, or they take care of their neighbor next door who maybe can't go to the grocery store, but they'll go grocery shopping for them. So they contribute back to the community in which they live, but also the greater community. And Rebecca can talk to you about one project that we've done together where after about a year, the residents started complaining to Rebecca and her team that they wanted more flowers planted out front, and they wanted more patio furniture, and they wanted a barbecue. Well, this was because they wanted to get together, and they were creating a sense of community within the walls of that building. And that, to me, when I heard about it, I went, yay, you know, they're starting to look outside themselves. They're not all about me anymore. They're looking to the community, and they want to have that. One of the problems that I see, we were the first HUD building west of the Mississippi. When HUD celebrated its 50th anniversary, they came to our organization and celebrated with us. But we've paid off that loan. HUD never came back to us and said, would you like to redo your loan? Would you like to take out another loan for another 50 years? We gave up that HUD designation, but we still have low-income housing people living with us. Now we need to renovate that building. Nobody is interested in maintaining these people in housing. And we find that as we look to other forms of providing care and services to folks who are elderly before they become homeless. As Zandra said, you know, they get put out on the street, or they lose their housing, the rent goes up. In San Diego, all of these apartments are being sold to developers. They're now high-end, multi-million-dollar condos. And I could do that with our Manor building. It has beautiful views of the harbor, gorgeous, but that's not our mission. We are trying now to raise money in order to continue to provide housing for those who are kind of on the edge. They're not Section 8, they're just above it. But if it wasn't for affordable housing, they would be out on the street. And so we are now, and that's my big push in government, in Sacramento and in Washington, because I do a lot of work in both those areas, is, hey, look at preventing homelessness. We have the homeless population, but you just keep adding to it every month because these people lose their housing. And Zandra told with financing and her resources because she got married. Okay, we need to look at these things. We need to help people maintain their housing and to maintain and stay contributing members of the community. We need to not shove them out because of our policy issues. We need to take a good hard look at all of those things. We established about 12 years ago a phrase, there is no health without housing. Now that's been changed to be health is housing, but you cannot get healthy when you're living under the bridge by the third bush with diabetes out of control, 911 to the emergency room, 11 times a year. We did a study within 12 months of coming into our program and providing housing, we were able to reduce and document the reduction of 73% of hospitalizations. Now, that's not only good for the participant, the person who's in the program, but it's good for our social services, our EMTs, our hospital emergency rooms, and my tax dollars, because I'm not paying for all of that care in the hospital. So by reducing healthcare needs, acute healthcare needs, providing for basic needs, socialization, the phrase now social determinants of healthcare, well, where was everybody talking about that 12 years ago? Nobody was talking about that until about 3 or 4 years ago. Duh, if you don't have a diabetic getting the right meals, of course they're going to end up in the hospital. So somebody who's in renal failure needs dialysis, they need a special diet, they need proper food. We need to take care of these people and prevent their hospitalizations, keep them off the streets, keep them out of police involvement and incarceration, as Zandra so touchingly mentioned. There are so many things that we can do. And I just feel very proud of the staff at St. Paul's who took this on as a real challenge. I thank the partners that we work with, CSH, Wakeland, and we're willing to work with anybody else. We've worked with CEI in Oakland. They have now taken up a homeless housing outreach program, and we will help anybody to replicate what we do because we just think it's the way to go to prevent homelessness and to help those who are homeless get back on their feet.
Wow. Thank you for everything you're doing. It's just extraordinary. I'll bet everyone's breathless right now. We are getting people who are asking how they could reach out to you and how they could learn to replicate this. So if we're able to share any of your information in the chat or who they could connect to at St. Paul's, that would be unbelievably great. So right now it kind of makes sense. Thank you so much, Cheryl. It makes sense to talk to Wakeland Housing. Cheryl mentioned that St. Paul's has been housing their homeless older adults in developments that Wakeland Housing has put together. And we're really excited because they have 4 projects happening in Los Angeles. 2 are due to be opened in a year and a half. And so I'd like to introduce you to Rebecca Louie. She can talk to you about what Wakeland Housing does and share some of the challenges that they face.
Hi, everyone. I'm Rebecca Louie. I'm with Wakeland Housing and Development Corporation. I'm the COO. Wakeland is a nonprofit affordable housing developer. We were over 20 years old now. I think we've been around since 1999. We started out primarily doing family affordable housing. So just, I assume people know what it is, but just in case, affordable housing is housing that is designated for people that are low income, and you try to ensure that they are paying an affordable share of their income towards rent. So sometimes that's locked in at 30%, or sometimes it's just done as an affordability calculation. We started moving into doing permanent supportive housing, which is affordable housing combined with intensive services to help people who have been homeless live independently. We have a bunch of different kinds. We have, supportive housing for transition age youth. We have it for adults who've been homeless, and, closest and dearest to our heart, I think, is our supportive housing for formerly homeless seniors. So our first project was in conjunction with St. Paul's PACE. It's Talmadge Gateway. It's, if you want to look it up, it's 60 units here in San Diego. Formerly homeless seniors with chronic health conditions that require them to have extra medical assistance and other assistance to live independently. St. Paul's PACE program provides the services there, along with Father Joe's, who provides some case management. We like to partner those two things. PACE has been, St. Paul's has been the most fantastic partner, and it really is, you know, I always quote Cheryl of saying that the PACE program really is all inclusive. They make sure that the residents have absolutely everything they need to live independently, stay healthy. I always really like they're very mission driven, but then they're also financially incentivized to take care of people. They get the same payment for them, whether the person lives healthy and needs very little medical attention or has to have a triple heart bypass, which I think we've had some of our residents have to have. So, you know, they really get in, they take care of them from the beginning, and it's been such a successful model. We've have a 98% retention rate. The only people who don't live there anymore have passed on, which is always sad, but we're always really happy that it happened in a home and not on the streets. Our residents have heartbreaking stories. Everything that all of you have said has really resonated with me from the things that I hear and see with our residents. The real benefit and huge benefit of this is, you know, affordable housing is very expensive. There's never enough resources for it. It takes forever. It's all the things that are frustrating about trying to get affordable housing built anywhere. You know, it's really nice to partner it with the PACE program, because that brings us the resources without us having to try to pay for it out of our operating budget like we do at some of our services at some of our properties. So it's just it's an enormous resource, and we liked it so much that we're replicating it. We have 2 more projects in partnership with St. Paul's PACE program under construction here in San Diego that will be very similar, except we'll also have a set aside in those ones for formerly homeless seniors with mental health diagnosis. So we'll have other partners in there working on that as well. And then we have 2 under construction in LA, one in South LA and one in Mid-City, that will be also very similar, serving those same residents. And we've got 2 more that, you know, are in the pipeline, and we hope to start construction on soon. So, you know, thinking about the challenges, I'd say the things we faced. So, you know, just because people were housed, we thought, yay, everything's going to be great for them. We got them off the streets, you know, it's going to be fantastic. Well, no, they're still super, super poor. They're still real poor. Like, they're still, you know, trying to survive on Social Security income, which is a pittance. You know, so even if you say, hey, only 30% of that is going to housing, well, we still had, and some of them didn't even have, you know, it can take a long time to get them on benefits. That's the first thing we try to do when anyone moves into our housing, is make sure that they're getting the, you know, pittance of entitlements, at least, that they are due to them. So we try to get them signed up to everything, and you get to see firsthand how wildly frustrating those systems are, and it can take a very long time. So we had people move in who literally had 0 incomes for the first, you know, 6 months that they were living with us. So there was a lot of food insecurity. St. Paul's really stepped in, and we quickly adjusted to that. That was one of our first wake up calls, was, hey, just because people are housed doesn't mean they have food. So we had to, you know, we have a lot of partnerships with the food bank, my staff. You know, the pandemic's been a real trial for us. I think we've delivered 150,000 pounds of food from the food bank since this pandemic started. Food insecurity is a really big one. And then just really, so the need for vouchers. So one of the things with affordable housing, there's a lot of different ways it can be set up. There's a lot of different programs, and we overlap them. It's always a little complicated, but vouchers are a fantastic thing for seniors, because if they have a Section 8 voucher attached to their unit, they're not going to pay more than 30% of their income for rent. So if their income is 0, their rent stays 0. You don't have to increase it every year. Seniors' incomes are not increasing. So it's very frustrating for us. We have affordable housing, you know, we have over 7,000 units. So we have a lot of seniors living in our housing, and we have to raise rents because of the way that they're structured. And you really see what a burden it is. It breaks my heart to have to raise rents on our seniors, knowing their incomes are not going up. So, you know, we see that, you know, how precarious their existence is, even if they're lucky enough to be in affordable housing where we are sensitive to these rent increases and try to make them minimal and have a lot of warnings. So yeah, I think that's my, but we're very excited to be in LA. The model of partnering the housing with really intensive medical assistance, because again, as I think everyone said here, man, is it rough to be on the streets when you are a senior, and man, does it take a toll on your health. It'll just break your heart when you're moving people in. You see people moving in with walkers and in wheelchairs, and you think, how did you survive? We have a resident that was treated for pancreatic cancer while he was living, in front of the McDonald's, and so he'd go get his treatment and then they just send him right back out. We had, so it takes a long time to get people stabilized. And I love like that Cheryl brought up the planting thing. It's a big success for us when we move people in who've been living these existences that are just, fraught and dangerous and survival based, and they don't get to think about anything beyond their moment and how are they going to survive through that day. So we consider it a really big victory when they start to argue with their neighbors or complain about the plantings or, bicker about the property management. As soon as I get an angry letter about the property manager, I'm delighted, because it means they've gotten to move beyond those basic survival needs and really start to be, just regular people who get to complain about the world around them. So.
Wow. Thank you so much, Rebecca. We could not be more thrilled that you guys are coming to Los Angeles. We really need you and your housing. So I just wanted to note that I can see those questions in the question and answer area. And after our next presenter, we'll be fielding those questions. But up next is an incredible warrior for homeless people in Los Angeles. She has years of experience, and currently she is the executive director of Housing Works, but also Celina Alvarez lives with the heart of a frontline worker, and we're really happy to have you here. Could you tell us a little bit about Housing Works and how you serve formerly homeless older adults and maybe the challenges that you face?
Hi, Jean, and hi, everyone. Yes, thank you. This is also inspiring. And, I came today with a whole framework of what I was going to talk about. And then I heard Zandre and I was like, oh, yeah, it's simple. We just need to emphasize the inept and system that we work under, and all the things that paralyze us and shackle us as a system that works in the system, as we do the work that each of us are doing every day. So like Jean mentioned, my name is Celina Alvarez, and I proudly represent Housing Works. I've been with Housing Works for going on 13 years. I've been doing this work for nearly 30 years. Our goal at Housing Works is really to take people off the streets, and then once they're housed, we continue to stay with them for as long as they need us to stick around, and then we support them through all life's up and downs. We were founded in 2003, but our work really didn't take off until about 2008 with the creation of our Mobile Integrated Services team. And then by 2015, we also embarked on a new venture within the workforce development realm. That was where we created our Empowerment Works team. They look at where a participant is in their life, understanding if they wish to seek employment, are they contemplating the pros and cons of employment, or do they simply want to volunteer or participate in community activities? Wherever they are in their life at the time of engagement is where we start. Our Mobile Integrated Services team is a field-based mobile supportive services team that does field-based case management, basically. We work from the streets and emergency rooms to get folks off the streets and into housing. Our MIST team currently serves a total of nearly 600 households in the San Gabriel Valley into North Hollywood, West Hollywood, Northeast LA, East LA, Boyle Heights, South LA, you get the drift. The folks we serve live in scattered site and single site settings. And once we house individuals, we really strive to ensure that they remain successfully housed. And as a result, we have a 95% retention rate. It used to be 98%, but it's dropped a bit. So we're at 95% at this time. Once we house people, they're very likely to remain successfully housed. And we really do this in the spirit of one person, one life, one relationship at a time, working with people to develop personal skills, confidence, resilience, and resources to manage their own life and really to build a fulfilling future. We do this in the spirit of always asking ourselves, who am I? The triple A's with an M. Who am I? Am I an assistant? Am I an advisor? Am I an advocate, or am I a mediator? Who am I in this person's life on a day-to-day basis? Because the way we engage individuals, our service approach really is dictated by the needs of the person. So every day that can look different based on what the person's needs are. So the narrative of the relationship is that when we're playing the role of an assistant, we really look at what the participant needs support to complete with maybe a personal task or a personal ownership of his or her or their life. And then the narrative of the relationship is that of advisor when the participant needs help processing aspects of a problem. When we are the advocate, the participant is having difficulty representing themselves. And then when we are the mediator, the participant is experiencing an adversarial dispute with an agency or an individual, and we really come in and we help mediate and advocate with the person we're serving. So some of the challenges we experience as we are doing this work, particularly, I was telling Jean recently that when I think about the work, when I get asked, what do you do in serving older adults? For us, it's really not just about serving older adults. It's really about just serving the human being that's being served and what are the needs of that person in the moment. Older adults have specific and very intentional needs that are needing to be paid attention to. But I think that what we experience in terms of challenges with serving older adults, it's experienced across the board. Something that I don't think we talk enough about in the sector is workforce turnover. How does workforce turnover actually affect the people being served, especially when we're talking about older adults? If you have a workforce, whether it be caretaking, the domestic workers who are doing that frontline work, or the workers who are doing the case workers, who are doing the case management on the front lines, what we're experiencing in the sector, at least in LA County right now, is huge turnover of the workforce on a weekly, monthly, and sometimes day-to-day basis. And so what does that do? How does that impact negatively the people that are being served when there's a constant turnover of staff that aren't remaining consistent with them? And then we have the challenges of what we know as the nonprofit industrial complex system. We're working in this system that basically asks us to assess people for acuity levels, bill for what Medi-Cal allows you to bill for, provide the services that the contractors or the philanthropists are saying they're going to fund you for. But really, and the nonprofits are in this position where we're trying to figure out how to do the work we know has to be done while meeting the requests of the folks who are in the powers, in the position of powers. We also see that resources are limited and inadequate, especially if you're poor. I want to highlight the fact that if you are a person of financial privilege, if you go into a boarding care, it looks different. A boarding care looks different for someone with financial privilege than it does for someone who doesn't have any financial security. So when you're poor and you go into a boarding care, it's not a nice looking house with a couple of caretakers and only a couple of people living there. It's an institution that looks like a nursing home, and it's a really sad environment in most instances. So on the bright side of things, what are we doing at Housing Works to be innovative in the way that we do what we do? Well, I'm really excited to hear about SCAN and the work that's also being done at St. Paul's, because we could surely, I look forward to connecting with you all offline after this call. One of the things that we've done at Housing Works over time is really figure out, here's that word again, Zandre, system. How do we work and navigate through a system that isn't adequately meeting the needs? And so we have this IHSS system that most of our older adults are really dependent on, but really it's a complicated system to navigate. And you're not really going to find the quality of a worker. It's really a crapshoot. You're going to find someone who needs a job and who deserves a job, but really the needs of the person being served aren't truly being taken into consideration. When we as employers are hiring for staff, we're looking for specific skill sets and for specific background that the person comes to us with. Our older adults and the people living in situations where they qualify for in-home supportive services, they often don't have the time, the resources, or the energy to be able to go through a recruiting process through the names of the IHSS workers. They just basically pick one, interview one, and have them come on board. And a lot of times it's not a great fit, but it's doing the minimum of what the person needs to have done. So one of the things that we've done is we really look at when a participant is in need of an IHSS worker, we understand who the person is, what they need, and then we go into the community and we recruit people who are hungry for working, maybe don't have the experience, but sure know what it takes to be a caretaker, and sure have the desire to be trained and understand what it is that we need in terms of their service to the person being served. And then we pay for their background check, and we just support them through navigating that system. So we match them with the person that needs the worker. And right now we have about 15 workers that we have recruited from the community who have been with us, with the participants we serve for well over 10 years. And these are all women, because we can't find men to do this kind of work. But we find these women who are down to do this very, very exhausting and complicated work. And they do it, and they do it well, and they feel relieved because they become our partner. They don't do it by themselves. They become our dyadic partner in the field. So if there's a problem with the participant, our case manager is there on site to work with and through all the issues that come up.
Wow, Celina, this has been just an incredible to hear from you and learn from you. And I've heard you're famous for what you've created with IHSS workers and how you've been able to retain them because you make them equal team members. And imagine with the highest acuity older adults, how difficult it would be to have a new person helping them shower every couple of weeks. And 10 years is just extraordinary. And we're really, really grateful for all the work you do. But because we're running out of time, I'm going to jump to some of the questions. Cheryl, could you tell us who pays you? How do you get compensated for providing PACE services?
Yeah, PACE is a combination of Medi-Cal and Medicare funding. And so if somebody's dual eligible, then we get dual eligible payments from Medicare and Medi-Cal. If somebody is 55, which is the minimum age we can enroll, if they're 55 and not eligible for Medicare, then we just get Medi-Cal payment. And we do fundraising. We fundraise heavily for these projects. So when somebody moves in, they get all brand new everything from blankets and pillows to towels to coffee pot to plates, and everything that they need is brand new. And we fundraise for all of that. We also fundraise along for additional personal care items. You know, we might buy lotion and baby powder and toothpaste at the store, but that's expensive stuff. And so we fundraise and provide for all of that also. So fundraising is a big part of what we do.
Well, that's fantastic. Thank you so much. And I see some of the answers have been typed in, so I'm not going to worry about those past answers. Eve, I was wondering, do you have a challenge keeping people enrolled in Medi-Cal? I think someone was wondering about that.
Yeah, so I saw that comment, and also that folks are not necessarily enrolled in Medicare, which makes them eligible for a whole bunch of benefits. And I've heard several of the speakers say that one of the first things you do, particularly Rebecca was saying, one of the first things you do is you get people access to the services and the benefits that they are eligible for. Continuous enrollment in Medi-Cal is very difficult. And so what we do is we have care navigators that really engage with the person. They're getting letters, or if they're experiencing homelessness, they're not getting letters and they're automatically losing their enrollment and they don't know. And because, like with the PACE site, we have enrollment from Medi-Cal as well as Medicare, we know when people are losing their eligibility because they're showing up on our list 1 month and they're not showing up the next. So a lot of our work is outreach to folks to help them understand what's going on and try and keep them continuously enrolled. And you know, because we're offered, because we're paid both by Medicare and Medicaid or Medi-Cal for those folks, oftentimes, you know, we can carry them the month until they get back enrolled so that they don't have a disjointed coverage where they don't lose coverage. So yes, it is a challenge, particularly for people who are marginally housed or experiencing homelessness. And really our solution is outreach, whether that's telephonic or, you know, community outreach, actually engaging with folks in person on, you know, on the streets.
Thank you so much, Eve. Is anybody of the panelists have interesting initiatives, other examples of wonderful programs that we haven't spoken about, but you'd like to talk about that serve older adults who are experiencing homelessness?
During COVID, it was very hard to reach people who were living in some of our facilities. And although we have the one project with Wakeland, we have 6 other buildings. And we also place people in the community in apartment buildings. And so reaching all of these folks was very hard because of COVID. So we turned 2 of our vans into what we call roving clinics. And we started taking care with a doctor or a therapist or, you know, nurse practitioner, whatever, out on the road. And that has been very, very effective, and taking the care to the people, because we had to close our centers and we couldn't bring people in. So providing healthcare and social services and all of the other determinants of healthcare, including food, you know, we also run food banks for our residents and our seniors, was very hard. So our roving clinics really filled the bill, and that was very innovative. So innovative that the staff liked it, the participants liked it. And so we fundraised, we raised $600,000, and now we're going to get 2 for real roving clinics that will be built out and able to take healthcare on the road to our seniors.
Oh, that's fantastically interesting. So we have another 3 minutes. Zandre, I think you wanted to.
Yeah, I just wanted to throw in there, not throw, but, you know, put something in there with AARP. I've heard people are using that system to navigate from homeless to food to medical. And also in Hollywood for our LGBTQ T community, they have the Village in Hollywood that has a heck of a platform with housing, medical. I mean, it just kind of covers it all. And they're kind of a separate entity away from everything, I guess, because it is LGBTQ. And then also PATH, you know, PATH is doing amazing work. I have to put that in there. They're doing amazing work with helping not only older, but everyone that comes through their door. You know, they're finding their way to help. And I'm still back at systems. We need to change the systems and the way they navigate through this crisis that we've been having for decades. We need to change the language. All right, that's it.
Celina, I see you're off mute. Would you like to leave one closing thought before we head over to Gary?
One closing thought. I don't know. I guess one of the things that I think people should walk away with is if you're a head of an agency, or if you have what we call power in an agency, I don't like that word, but that's what it is, then I encourage you to think about pushing back when it doesn't make sense.
Fantastic. Really
Well, why don't I go ahead and jump in, and something else that you said, Celina, really stuck with me in the context where there are particular needs of older adults, and particular, potential challenges, health or otherwise, there may not need to be a particularly different approach. Instead, you meet the person where they're at and provide them what they need in order to get stably housed and then to reintegrate. And in kind of that approach of what do people need is universal. And I really appreciate that. And I really appreciate the time and care that each one of you on a daily basis take to really make an impact on your communities and to advocate for your communities and try to navigate systems that were not designed well to actually lift people up. As Andre said, it's a system that was really designed to disenfranchise particular segments of our population, and we have to recognize that and fight against that. And I really appreciate the work of Dr. Margot Kushel and your colleagues that you continue to really provide critical insights based on really a terrific study. And I know that we have a lot more work to do, but I know that working collectively and together and listening together, we're going to be able to really change the arc of instead of increasing numbers of people experiencing homelessness, to actually house increasing numbers in ways that we actually have more housing stability in our region and our systems. So again, I thank everyone who's with us here today. We are going to include additional information from our panelists on the event page. For those of you who have registered and are with us, we will send you a note that provides a link to both highlights of this panel and also a full recording so that you can engage with us. If you have any questions from any of our panelists, feel free to contact me or the Homelessness Policy Research Institute directly, and we'll make sure to be able to make that contact. So with that, we'll go ahead and conclude for today. Thank you to all for being with us. Bye-bye.